we are ready to begin. Hello, everybody, and welcome to the O'Brien Institute and Department of Community Health Sciences webinar series at the University of Calgary. I would first like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, and Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. I'm Jillian Curry, and I'm a health economist and adjunct associate professor here at the University of Calgary, and also a proud member of Dr. Marshall's research team. Before I introduce Dr. Marshall, who is today's speaker, a few housekeeping items. I wanted to let you know to please ask your questions in the Q&A box in the Zoom platform. Please ask them as you have them throughout the seminar. There will be time set aside at the end of the presentation to go through the questions and answers. If we don't get to all the questions and answers, we do apologize in advance, but we will have them answered and follow up with you after the event. So now to introduce today's speaker, Deborah Marshall is a professor at the University of Calgary and also holds the Arthur J. E. Child Chair Rheumatology Research. She's a health services researcher and health economist, leading a program of applied research using patient preferences, patient engagement, and simulation modeling methods in the context of precision medicine. She has experience in technology assessment agencies, academia, and pharmaceutical and diagnostics industry research settings in Canada, the United States, and Europe. She's the co-lead for the health economics activities within CIHR and Genome Canada research programs in precision medicine and childhood arthritis and rare genetic diseases, and is also the co-PI for Imagine, Inflammation, Microbiome, and Alimentation, a CIHR strategy for patient-oriented research, chronic disease network, and the co-lead of the patient engagement theme in that program of work. She's the 2020 holder of a Canadian Academy of Health Sciences Fellowship Award and 2019 Killam Annual Professorship, as well as in 2019, the Jill M. Sanders Award of Excellence in Health Technology Assessment from the CADITH agency. I won't go back further than 2019 for all the accolades that I could say, otherwise I would take up all the time. And I would like to instead hand off to Dr. Marshall to speak about the Imagine Project.
Great. Thank you, Dr. Curry. And I'm glad you said that whole name out loud and did a very nice job of it, because Imagine in Spore is quite an alphabet soup of acronyms. And that's why I have it spelled out on the front page here. And what I want to do today is really have a chat and introduce you to our Imagine Spore program, and focusing specifically around the patient-oriented research aspect and patient engagement research aspect. So Imagine, just to say this once at the beginning, is the Inflammation, Microbiome, Alimentation, Gastro-Intestinal, and Neuropsychiatric Effects program. So a very long name, but a nice acronym. And it's one of the SPOR, which is the Strategy for Patient-Oriented Research, chronic disease networks. So having gotten through that, I will use the acronyms only moving forward. So I really appreciate you joining today. And I understand that actually, and realized this morning that it's reading week. So I don't know how many people were able to join, but if you have, I really appreciate it, because indeed the polar vortex seems to have left here in Calgary, and it's reading week. So I hope that there are lots of people not here out there doing something nice, but this session will be recorded. So hopefully you can find it online if you're interested. But I really wanted to take the opportunity to talk about Imagine I don't recall that we've actually had a presentation at Community Health Sciences around Imagine. And sadly, in many ways, but also happily, I guess, for me, I've been involved in Imagine from the beginning, which is happy. Patient-oriented research is a strong component of my portfolio. And it's really been a fantastic program with, I think, huge opportunity. The sad part is, of course, that Dr. Glenda McQueen passed away in 2020. She was the co-principal investigator of Imagine. So the sad part is that now I'm the co-investigator of Imagine. And we're missing and sorry not to have Glenda as part of our team anymore. But the show and the program are going on. We have an excellent team, and I just will, for you today, talk about and give you just a brief overview of SPORE for those of you who might not be as familiar. And then I'll spend a little bit of time talking about Imagine itself and how it's structured and the research themes. There are a number of them, so I won't be talking about all the research going on in Imagine. And then in the third piece, what I'll do is do a little bit of a more detailed discussion about a few, and again, it's just a few of our particular patient-oriented research, patient engagement research subprojects in Imagine, where we are working specifically with our patient partners. We have a very fabulous patient research partnership in Imagine, and we have subprojects based in Calgary that I just wanted to tell you a little bit about, and really also opportunities for you to engage patient as partners, and also maybe connect with us in Imagine if you're interested in any further details. So that's my plan for today. I have tried to keep this relatively short so that we have time for discussion. So most of you probably know, but just in case, SPORE is the Strategy for Patient-Oriented Research. And this was established in Canada over a decade ago now. You know, time flies, and I have a timeline in 2 slides from here, which I'll show you. But we're really privileged in Canada that our leaders had the foresight to think about this and really create a whole strategy. And with the overall overarching mandate that by 2025, which isn't that far away anymore, health outcomes in Canada will be demonstrably improved and the healthcare experience for patients will be enhanced through integration of evidence at all levels of the health system. So that's a very broad, lofty goal, but there's a lot of really important aspects to trying to achieve that. And I think for those of you who've been around for a while, I think you will have noticed, you can hardly help but notice that we do research differently than we did 2 decades ago. And I think it's really been a fascinating journey. It has been for me. It's made me rethink how we do things. And I think even though some of us might be somewhat tiring of this expression, it really does capture really well. And that is, you know, the whole intent of ensuring that the right patient receives the right information at the right time. That sort of encapsulates the whole intention of this. And as a consequence, permeates the way we think about research, design research, execute research, and also interpret research. So this is SPORE. We're very privileged in Canada to have such a strategy and have amazing resources and support for this approach. And when SPORE was launched, they had a large funding competition. These are fairly substantial grants, and there were 5 networks plus 2 additional groups that were funded. One is, and you might be, I'm sure you are familiar with many of these. So Childbright, the Access Open Mind, so this mental health, chronic pain network. Imagine I put in the middle since this is about Imagine. And the kidney, the CanSolve study. So probably many of you are familiar with that study as well. We're really privileged because it's also based here in Calgary. So Imagine is co-led between Calgary and McMaster universities, and Solve is also based here. So Calgary and the University of Calgary has done very well in terms of the strategy for patient-oriented research. We also have Diabetes Action, and there's also the Primary Healthcare Innovations Networks. So these are the chronic disease networks. And this is that timeline that I was talking to you about earlier. So it's really quite interesting. And I drafted this out when I was looking through sort of the different paperworks and just sort of picked out some of the highlights of some of the things that have happened in the context of SPORE. And, so the launch was back in 2011, which shockingly is now a decade ago. And one of the things that might be useful, and I didn't put it in this deck, but if you're not familiar with it, is that a few years after SPORE started, there was this SPORE engagement framework that was developed. And it really gives us an outline of what is patient engagement, what is patient-oriented research, what are the elements of it. And this is a really useful reference point if you're doing patient-oriented research. There was also a concerted effort for capacity development in SPORE that was launched in 2015. We also have something called the C, which is the SPORE Evidence Alliance, and this really is alphabet soup of acronyms, so apologies, but they are all spelt out here. And then also a really important aspect is that there were these SPORE support units. So all of you would be familiar with the support units. We have an excellent group of support units here in Alberta. We were one of the first to get ours awarded and up and running. And I think we're very privileged and fortunate to be able to have that. And I won't talk about the details of it, but if you're not familiar with them, please do explore and identify where and how they might be able to help you in support your research. Most of the other provinces now have SPORE support units, and these are designed to try and help stimulate SPORE-related or patient-oriented research. So those are happening alongside here across this timeline. In 2020, despite the pandemic, there was a lot of activity going on. And one of the things is that there's been an update to the patient engagement framework. Many of the, well, all of the SPOREs actually were involved in this update. Imagine was part of that. The first manuscript is coming out soon. I know it's under review right now. So there will be a new framework for SPORE patient engagement. And then also some of you may be familiar and involved with the Canadian Data Platform and the DASH, which is the Data Access Support Hub, and the Health Data Research Network Canada, alphabet soup again, where they're really trying to develop repositories and inventories of algorithms for using administrative data and to try to standardize and make them accessible for people. So lots of resources. I know in the last decade for me as a researcher in Canada, I've been very excited about the accessibility to data, the support that's been available, et cetera. And a lot of this has been through the SPORE initiative. So thank you to the leaders who made this happen. There is this very nice document, which I have referenced here in the bottom, although I understand the bottom of the slides might not be fully viewable. But this is on the CIHR SPORE website, and this is the vision and the objective guiding principles, and also the desired outcomes of patient engagement. And I think this really nicely encapsulates the intention of the strategy for patient-oriented research, with a vision that patients are active partners in research, leading to improved health outcomes and an improved and enhanced healthcare system. And I won't go through all of these. I have a couple more slides, but I think this is a very good reference for you if you're doing patient-oriented research. And I think even though the principles are at the bottom, I guess the way here is it's being set at the bottom because they are the underpinning and the foundation and the guiding principles of all of this work, so that there's inclusiveness, there's support appropriately, mutual respect, and co-building that really integrates patient engagement into our research. And one of the terms that comes up very frequently with dealing with patients and patient engagement research is that it needs to be meaningful engagement, and that is the intent of this whole strategy. So let's just dive into a couple definitions. What is patient-oriented research? It's conducted by multidisciplinary teams in partnership with relevant stakeholders, with the idea of applying that knowledge that is generated to improve systems and practices. And the whole idea is that, patients are at the center, and that they're partners in research. I think that's a key word. And again, the idea is that there's engagement that's meaningful and active and collaborative, not tokenism. I'm sure many of you have heard that term. And I think maybe in the beginning, and I think as we were learning how to do patient-oriented research, sometimes that might have been the case. We knew that we should be involving patients, but maybe didn't know how to do so. And there's been huge advances and learnings on all sides in the last 5 years or so about how we do this, what methods are available, what are appropriate strategies and approaches. And I think we've come a long way, although I think we have a long way to go still. And I guess fundamentally, you might ask, although I think there's some obviousness to this, why would we want to do patient-oriented research? Well, fundamentally, because we want to achieve benefits that matter to patients. And we all want an improved healthcare system. I'm sure all of us have had experiences as patients in one way or another. And we want a good healthcare system to look after ourselves, and also our loved ones and friends and families. And we do want to contribute to cost effectiveness. I am a health economist by training. We want a better situation with respect to cost effectiveness, because it's all about opportunity cost. And if we do things that are cost effective, and if we do them well, then we can use our limited resources to expand, to provide other services as well. So these are just some of the principles here. Patients are at the heart of SPOR, and patients have expertise through their lived experience. And this is what, in part, they often bring a host of other skill sets as well, but this is at the heart of what they bring to the strategy for patient-oriented research. And they need to be meaningfully involved as much as possible to make our research responsive to these needs. So that is the background. I know it was quick, but I want to move on to Imagine. Imagine is one of 5, as I showed you earlier, chronic disease networks. And we're really looking at the interactions between inflammation, microbiome, diet, and mental health in IBD, IBS patients. So that includes Crohn's disease as well. And we also have healthy cohorts, and I'll show you that in a minute. But it's a network of 17 hospitals, universities. It includes researchers, patients, clinicians, and it's all across Canada. And the idea and the mission of Imagine is to transform the management of IBD and IBS associated with mental health issues and these disorders. Of course, that's huge. It's one statement, but it's a very big area and a very fascinating and complex area. study. So the main cohort study is called MAGIC. We have some really fabulous acronyms in Imagine with a main cohort study called MAGIC. And the idea here is to look at genes, diet, and mental health impact on the gut microbiome. And subjects are recruited. They're assessed annually for 4 years. So it's a big, complex study. We collect blood, urine, and stool samples, and they complete online questionnaires, which are quite extensive, I have to confess, but there's a lot of information because, you know, we're just learning and we're very early on in trying to understand the microbiome. So we need a lot of information because we're still very much in the exploratory phase about these relationships between the microbiome and our mental health and our overall health. So we don't have any results yet. I have to say it's an ambitious project and there's tremendous progress, but there will be 8,000 subjects involved across Canada. And these are the cohorts. As I said, there's Crohn's disease, ulcerative colitis, irritable bowel syndrome, and then 2,000 healthies. So there's 2,000 in each cohort. I didn't put this slide in here, but we are approaching 5,000 recruitments to date. Very sadly, COVID, like with many other studies, has slowed down the recruitment. We're still getting a little bit of a trickle of recruitment, but we are have already recruited close to 5,000. So well on the way, but also very much keen. If you are interested in joining the Imagine study, everybody's eligible because you don't have to have one of these inflammatory bowel disease conditions. Healthy participants are also welcome. So please get in touch if you're interested. So this is our main cohort in all the different themes. So you can see there's multiple research projects that were in the main grant proposal directly associated with the microbiome. So this includes fecal microbial transplant, for example, and diet and environment is a key pillar of research in our program. I won't go through all of these because it's a complex program, and I do want to spend a few minutes talking about our patient engagement programs. Large component on psychiatry and mental health with a whole lot of different studies looking at things ranging from, you know, how do we manage stress all the way to looking at suicide risk. Of course, this has been very concerning and interesting in the context of our current pandemic. And I think these studies will be particularly interesting to learn more. And then we have health services research projects here in the middle, and there's a whole range between guidelines and telemedicine. Lots of patient engagement projects. I will mention some of these to you momentarily. We also have a theme that's cross-cutting in terms of sex and gender. And also we have a kids section, which is the pediatrics, where we're looking at children with IBD, IBS, etc., and looking at their diet and other kinds of aspects of management. I do want to take a moment and say thanks to all of our UC-based co-investigators. This probably isn't a comprehensive list, but these are our main team. I have a shout out here in particular, and hats off to Remo Panaccioni, who is the University of Calgary site director, and all of our co-investigators here who are actively engaged in multiple projects, both across the Imagine cohort, but also with specific sub-studies based at University of Calgary. And a big shout out to our Imagine research team, Simone Withicum, Blessing and Nav, Nazrat, I won't go through them all, Sandra, whom I'll talk about in a minute, and some of my team members are part-time involved in this as well. And then we have two students based here at University of Calgary as well. So a fantastic team and a lot of management and complexity to this research program. So let me spend a couple of minutes on the health services patient engagement projects. And I've only picked a couple for some discussion because we don't have a lot of time to talk about all these different aspects. And let me first start with this slide, which introduces our patient research partners. Not all of them, and I notice we don't have a couple of pictures, photos available for our team. And this has grown, actually, we have, I think it's 23 patient research partners in Imagine now. And they work very closely, and I'll show you the governance structure in a minute, but they work very closely with Imagine and really helped us to ensure that the network addresses the unique needs of patients, all with the aim of trying to improve care and quality of life for people living with GI diseases. And they contribute in lots of different ways. I'll only be able to speak about a little bit of it today, but they serve as committee members. They're part of our governance structure. They're working group members. They work as co-researchers, and they also co-lead various research projects in Imagine. So they're very embedded in our program and engaged, and we meet with them regularly. And to be honest, they come up with a lot of really good ideas and additional things that we can build into our program. And this just gives you a little snapshot of the governance. So I showed you the themes earlier, but this is gives you the idea that even when we submitted our grant, we had a patient lead co-leading with the leads of each of the different components of our studies. So here are the names of some of our Imagine patient research partners. And you may recognize some of them because you may have worked with some of them. And they are included in all of the different components of our work. And I just want to give a shout also specifically to the patient engagement theme, which I co-lead with Sandra Zelensky, who is there. She's also very involved in Alberta Spore support unit here, which is led by Maria Santana. And Sandra is a key member of that support unit. And I actually feel a little lonely today, Sandra. Where are you? Because Sandra and I are quite enjoy co-presenting things, and we usually co-present these kinds of presentations. And actually, I also must say that many of these slides were actually developed by Sandra. She also has the talent of creating really excellent slides, and we have presented these in our Imagine team in various formats before. So thank you, Sandra. I don't know if you're out there, but she certainly is a key player on this team and has been actively involved not only in Imagine, but other research projects in Canada, in Calgary, and in other places as well. So let me also say that Imagine sponsored part of the role and idea of SPOR is to build capacity, like I said earlier. And we sponsored through Imagine 2 patient and community engagement research cohorts. And here they are. You can see their lovely faces. One was the IBD national team, which they self-proclaimed their name to be the mob. That's what they call themselves. And they undertook the PACER program and studied the psychosocial relationship between individuals with IBD and food. And then we also had an Alberta-based team, and here they are, looking at what resources are available to patients with IBD after they get a diagnosis. And so the last year in 2019 and finishing off into 2020, they were able to do this research and this work and the training, which by the way is a year long. And they graduated again, sadly but happily, they happily graduated in June 2020, sadly, because they weren't able to actually go in person to the graduation ceremony and receive their certificate from Dr. Ed McCauley, President McCauley, from the University of Calgary. So they had to do it virtually, but we do a lot of things virtually these days. Just to give you a snapshot or remind you, the PACER training program is situated as a distance learning program at the University of Calgary Continuing Education. And this is in concert with our Alberta Spore support unit. And there's 3 components. There's 3 courses to the training. One is research and consultation skills. It's about 40 hours that's done online. And then a second course, which is around the theoretical foundations around engagement research, which is another 40 hours. And then in that time, a project is identified and put forward, and ethics is developed and submitted for approval. And then our trainees then do an internship, and they actually execute a research project that's been ethics approved, which is, we say here 80 hours, it's probably more than that. And the output of that is a pretty robust report, and this constitutes the overall PACER training program. So this was something that's being developed, and to my knowledge is still unique worldwide. In Alberta, I think it's the only place in the world that has a certificate program for patient engagement. It's really been quite an experience. I was one of the founding members of PACER, along with Nancy Marlette, whom all of you would know, and Tracy Wozlik, who is an Alberta Health Services executive team leader. And it's really changed the way we think about research, creating new patient roles and relationships where patients really are part of the team. And we've actually dubbed this and called it a twin innovation, where we've had major impact, I think, in terms of increasing capacity of patients to engage, creating new roles in healthcare planning and also in research. And many PACERs who graduate actually go on to be, and this was actually the origination of this, go on to be part of the strategic clinical networks, which is, all of you know, multidisciplinary teams around certain areas in Alberta, really all focused on how to improve the effectiveness and efficiency of care. And they've been tremendous partners in this whole process. And they also now have gone on to be members of CHR committees and review committees and parts of our research grants, et cetera. So there's been a fundamental change in the culture of how we do research. So let me end now in a couple minutes with a couple more slides, just to give you some examples. And this is just a list of sort of this broad range of patient engagement project examples. I won't go through all of them, but we have preferences studies going on, working with our patient research partners, and also, of course, patients are subjects in these studies because they're the ones filling out the surveys. We have a recruitment and retention study that's sort of an internal study to try and help us think about ways we can improve our imagined processes. Now, I will talk about that one. We have a priority setting study going on, a la the James Lind Alliance, which many of you may be familiar with. We've done one in pediatrics, and we're now working through this for the overall project. We have a healthcare resource use and costing health economic study going on. We have on and on. So this gives you an idea, and please note this graphic was actually designed by Sandra Zielinski to try and delineate all the different kinds of range of activities that our patient partners are involved in. So just a couple minutes on the patient recruitment and retention. This is an internal type study where we're really trying to figure out, you know, in all studies, recruitment and retention is challenging. Magic is particularly so. It's a 4-year study, so it's hard to get people to do so, and it's a lot. Urine, stool, blood required annually, plus surveys. So we know we can do better, although we do very well, and we're really pleased, and our staff are amazing at recruiting and engaging patients to be involved. But we were all struggling a little bit to get healthy controls actually too. And so our patient research partners, and 10 of them actually were involved in this, worked to do semi-structured interviews, and they interviewed 26 participants from 6 provinces across Canada to try to understand, you know, what are the motivations to be in studies like Imagine, you know, what are the barriers, how could we improve our recruitment and retention, and how might we implement this. And they looked at these key motivators, and when reviewing and analyzing the data, basically synthesize this into 4 components. And they were convenience, experience, so having a good experience in the recruitment, in the interactions with people, study staff, good communications, and also compensation. And I do want to highlight that when we talk about compensation, that doesn't always mean money. For many people, compensation can come in a lot of different forms, and that is feeling valued or being recognized or acknowledged. So please make sure when you read the term compensation, you think about that in a broad context. And this also comes out in the strategy for patient-oriented research framework. If you go to the website on CHR, that compensation can be of many different kinds. So these were the themes that they came out with, and we're actually in the process of trying to see how we can translate that into improving our recruitment and retention processes. And I'll just highlight here the poster that was not only accepted, but also presented at the Alberta Spore Support Unit, which is the AV Spore U virtual conference that occurred in 2020. And you can see that Sandra was the lead author here of this publication, and there were multiple patient engagement research partners on here. And this was also submitted to the Crohn's and Colitis Congress and presented by Sandra and others at that team. So that's some of the work we've been doing. We also have a patient preferences study going on using a discrete choice experiment, which is quantitatively looking at how patients weigh the risk and benefits of alternative treatments. This was particularly interesting in the context of fecal microbial transplant, but also includes other kinds of treatments. We're almost finished recruiting. We need 9 more people to meet our 200 target. This is being fielded in Alberta, Ontario, and Manitoba. And the kids liked it. And we're now adapting this also to IBD in children. So we're doing a pediatric children looking at study looking at parents, caregivers, and their children in Alberta, Ontario, and Nova Scotia. And for those of you who may not be familiar, a discrete choice experiment can look something like this, but it's basically a survey methodology which allows us to, using an experimental design, determine which aspect, and here we have adverse effects, events, remission, route of delivery, preparation, time, and frequency. So these attributes and characteristics of treatments, which things are most important? And what we do is we ask people to go through a series of questions where they choose one treatment or the other, and then we can statistically determine how much they actually prefer or how much they value remission compared to the risk of an adverse event, for example. So this is in field and also in development in the PEDS, and this is part of what the work we're doing. I mentioned the healthcare research health economics study, and in this study we're looking at healthcare resource use and costs of people with IBS in Alberta, Manitoba, and Ontario, and we're going to compare to IBD and healthy controls. And we're using both the rich data sources with Imagine, and I didn't show the list here, but we're collecting a wide range of variables, as you can guess, ranging from quality of life to mental health instruments, survey instruments that are validated, and as well as a lot of nutrition and diet variables, as well as comorbidities, etc. So we have this rich clinical data from Imagine, which will be linked with the administrative data in each of the provinces. And we're about to get started on that soon. We did just get ethics approved in Alberta, I think last week or this week. And we're moving forward with the details of the analysis plan. And then I guess this was, oh, where did my other one go? Oh, I think I have it back here. I might have moved it. Sorry, I want to show you one more. Oh, I think I deleted it from the deck. Ha! Oh my goodness. Anyway, I'll just tell you about it because one of the studies that we have going on right now, and I was just on a conference call about that briefly before this session, is a study that's going to be looking at engagement of patients and the level of engagement. So what we do is we have a comparative study working with, in partnership with the Alberta and the BC SPOR support units. And we're going to have 2 project groups. And these project groups are going to be both given the same research question, which is going to be around fecal microbial transplant. No, it's not. It's going to be on tapering of biologics, and they will be examining and executing the qualitative research to inform a preferences study. And in that context, what they're going to do is go through the whole process, and the 2 groups will differ a little bit, and they will be going through the whole process of qualitative research to look at what difference does it make, or what are the processes and how are they different with respect to the outcomes of the research, like what conclusions they come to, but also the processes and the level of engagement and how they go about executing the research. So we're about to launch that. We're super excited, and we are recruiting. We've almost filled all the roles in the 2 project groups. But if you're interested in that, and I really hope that some people out there might be, we are in particular looking for from researchers, people who have some experience with research, qualitative research, to participate in that group. So with that, I will close, and hopefully I can find that study design in the meantime. And I will ask Jillian, I think is the one who can actually see you, and see if there's any questions in the chat box in the meantime. So thank you very much. And huge thanks to all our funders and supporters. As you can imagine, in a large study like this, that is quite an extensive list. And I did have a slide with a thank you to all of them, but it seems to be gone missing. So.
Thank you very much, Deborah. If we were in person, you would hear clapping from everybody.
You provided it yourself. Thank you.
I'll just do that part. We do have some questions. So first of all, I'm going to pair 2 questions. So it's going to be a 2-part question. So just talk a little bit. I think you talked a lot about meaningful engagement of patients and sort of how you distinguish that from maybe what you called the token sort of stuff that might have happened earlier on. So just speak a little bit more about what is required for meaningful patient engagement. And then the sort of second part of the question is, can you talk a little bit about the downsides to patient-oriented research or the challenges?
Oh, absolutely. Thank you for those questions. They're really great questions. And absolutely, that is a challenge. So I think, in fact, I could pull up a different slide deck. I didn't put it in here, but there are multiple elements to that. I think to have meaningful engagement, one, I think it's about the intent, first of all, of the researcher, and that is that you're sincere in wanting to engage. I'd say that's the very first step, and that you're open to listening and engaging and having a dialogue, a meaningful dialogue. I think that's absolutely critical. It's kind of attitude, I think, is the very first step. The other is that you plan for it. So patient engagement takes time, and meaningful patient engagement isn't about checking a box or saying, oh, I have to find a patient to be on my grant. And all of us have been in that situation, of course, because, grants have really short deadlines sometimes, and sometimes it's a panic for everything. Sorry, I shouldn't have said that publicly, but sometimes it's time pressed to get everything together. So sometimes that is a challenge. But I think the idea is you have to plan for it. Because you have to be able to have a conversation, and you want people involved early. So that's why I already referenced the idea of grants, because you have to be able to have time to think and co-design and co-create basically what it is you want to research. So I think that's part of it. It's the intent, the earliness to allow time, because it does take time. And also being willing and able to have those conversations and being willing to rethink things. I know for me, my whole journey in learning about patient engagement and working closely with patient partners has changed the way I think about research and the way I do research. So I think those are absolutely key things. In order for those things to happen, there are certain conditions, and that is part of those guiding principles about having respect, mutual respect, creating relationships, and being able to engage in a way that the partners become partners and that there are partnerships. So it's all about the relationship building. It all sounds good, and this is the questions around what are some of the challenges. And I think some of the myths and challenges around patient engagement are that it's easy or it's always super positive and it's great. Well, I think it is, but I think also you have to realize that it does take time. It also takes resources. And remember, I'm a health economist, so time is money. Those are resources. Time is actually one of our most precious resources, of course. So you have to be able to adjust and think about how you can, what's reasonable, what's realistic, how you can engage. And the other thing that does become a challenge, of course, is just scheduling, for example. The larger a team gets and the more people that are involved, that can be a challenge. The other thing is, well, patients who are living the experience are living the experience. And sometimes they aren't well and they can't be part of the team. So that can be a challenge too. We all have different health issues, but in particular, if you're working with people with severe disease or diseases that can be really hard to function fully or at a certain level, you have to think about how to adjust and adapt and accommodate those things. So there's a lot of thinking and planning and flexibility that I think is required. But I also think there's a lot of rewards to it.
Thank you. Another question, and again, I'm linking two questions together. One person asked about how do you ensure that the patient partners in your work are representative of the diverse patient population in Canada in terms of race or education or occupation. Another person asked about the male-female ratio. And what work do you think still needs to be done to ensure we work alongside a diverse group of patient partners?
Yeah, really great questions and totally agree with you. One thing I would say just as a caution is I don't think we can ever in a research project really represent all of the diverse aspects, because I guess that's a long list if you really worked through that. I think to me it's about at least being cognizant and aware and thinking about those aspects of diversity and what voices you want to bring into play and you think are important to be represented. Uh, I think the word representativeness is the older I get as a researcher, the harder I think it is to actually think about representativeness means. Because we are really diverse. So to me, it's just being cognizant of that, reaching out and trying to achieve at least some aspects of diversity within your patient groups. And one of the things we've talked about a lot with our patient research partners is that I would really advise never, for instance, to have, a single patient on a research project. I think you should always be planning that you would have at least a couple, if not a few more, if you're able to, within this constraints of your time and budget, because remember, that's a real thing too when we're doing research, at least to be cognizant of it and always have more than one patient involved. I should also mention, and this falls into that, and I alluded to it in the compensation aspect, it's really important to have conversations about what is expected with patient partners and what can be provided to them in terms of compensation. And that could be in lots of different ways. It might be the satisfaction of making a contribution so that it's a volunteer kind of engagement, which sometimes it is. On some research projects, we've been able to budget in, because we planned it ahead of time, early on as we were developing the grant, budgets for compensating patient partners with money in some form. And there are guidelines I should bring to your attention on the CIHR website that we developed a couple of years ago, I think now, around guidelines for compensation and what's reasonable. And the reality is there's a whole range of different levels of that, and you should have those discussions. Another type of compensation is acknowledgement and recognition. You notice that our patient partners are invited and are involved in publications and knowledge translation activities, etc. So these are all sorts of different forms of compensation.
Thank you. I think we have time for one more quick question, and that is, there was a question about, you mentioned healthy participants are being sought for your MAGIC study, and so how does one get the information about that and sign up if they would like to do so?
Oh, excellent. Well, you can either email me or you can just go to our Imagine website and sign up. We'd be very happy. Also, I don't know if perhaps our study coordinator, Simone Withicombe, is on the phone, but Simone Withicombe is based here. I don't know. I see Cassandra maybe is on this. If you're able to put that in the chat box, I can't see that right now. But I'm also very happy, Brittany or Liz, if you'd be able to circulate that to the distribution list afterwards. We do have some wonderful recruitment posters that were actually developed by our patient research partners, which essentially say, we want poop. So we'd be very happy to have you participate. So I can certainly circulate that. And I'm sorry, for whatever reasons, my screen I don't think is sharing anymore, because I do have that. I'm not quite sure what happened, but I think it stopped. So, or maybe somebody cut me off, I don't know, but I don't seem to be able to do that.
No problem. I think that we're going to arrange for that website to be shared. It's been shared in the chat box, so everyone should be able to see that.
Thank you. Oh, good. I'm glad you were able to, because I have it, but I don't have my hands on it right now.
Yeah. So it's 12:55, so we're a little bit over our official time, but all that remains, I think, as I said, if any of the questions were not able to be answered, we will follow up. And what I would like to do now is just thank you to all the participants and everyone who asked questions. And thank you especially to our speaker, Dr. Marshall. Thank you very much. An amazing program of work. I knew a little bit about it, but it's huge and it's really impressive. So thank you very much for sharing about it today.
Excellent. Thank you so much for joining me today.
We'll see you all next week at the next rounds. Have a good weekend.
Bye-bye.
Bye-bye.